Everyone wants to improve healthcare, but who do you trust enough to take your private health information and do things that are designed to make care better? I'm Andy Reynolds with NCQA. Today on Quality Matters, the second in a two-part series, In Data We Trust. This episode is titled Sex, Gender, Lawyers, and the Law. Our guests are Kellan Baker, Executive Director of the Whitman-Walker Institute in Washington, D.C., and Carl Streed, a primary care doctor at the Boston University Chobanian and Avidzian School of Medicine and the research lead at Boston Medical Center's Gender Care Center.
Welcome to Quality Matters. We appreciate your being here.
Thanks for having us.
We're talking today about SOGI data. SOGI stands for Sexual Orientation and Gender Identity. Kellan, let's start with you. What are SOGI data and why do they matter in healthcare today?
SOGI data, meaning sexual orientation and gender identity data, are important demographic data. They're important elements of identity. Everyone has a sexual orientation and a gender identity. Somebody might identify their sexual orientation, for example, as heterosexual or straight. They also might identify their sexual orientation as gay, lesbian, bisexual, queer, or any number of other terms. Gender identity is just about who you are in terms of gender. So somebody's gender might be man, might be woman. Transgender people can have any gender identity, but essentially it means somebody's gender is different from the sex they were assigned at birth.
Carl, you are an expert about how policy plays out at the clinical level out in the field. Why do SOGI data matter?
Without SOGI data, we are missing a vital component of people's identity as it relates to their health. So SOGI data matter because they are clinical components of identity, and how society treats people based on their identity can affect their health, their ability to access healthcare, any number of factors that affect their well-being. SOGI data in the clinical setting really does influence how we account for people's health conditions and how we to tailor interventions to improve their long-term health.
It's important to think about sexual orientation and gender identity together, in as much as it's important to think about all demographic variables together, because people don't live single issue or sort of single identity lives. People live at the complex intersections of multiple aspects of identity. Somebody has a sexual orientation, they have a gender identity, they come from a particular racial background, ethnicity, geography, disability. So we see these data as a critical element of quality, because to make sure that you're giving everyone high quality care, you have to be able to stratify by different elements of identity and investigate patterns of access or outcomes that differ for people on the basis of a variable like race or sexual orientation or gender identity. And data collection is a really important tool for making sure that people are seen, their voices are heard, and their experiences and their lives matter.
What is special or not special about SOGI data?
SOGI data are often thought of as being more sensitive than other demographic data, which is really the wrong way to think about it. But it's really important to make sure that these data have a lot of privacy and confidentiality protections attached to them. But that's the case with any data. We're all looking to gather this information about sexual orientation, gender identity, race, ethnicity, language, etc., to make sure that people are getting the healthcare they need. So there really is nothing different or special about sexual orientation and gender identity data.
There's a misconception that SOGI data are dangerous to collect or frightening for institutions to hold on to. This sense of exceptionalism has created more barriers for care for LGBTQ individuals. When we treat SOGI data as more sensitive than other data, we are essentially saying that this is a dangerous identity, or this is difficult to understand or treat. SOGI data is no different than any other personal data. Unfortunately, historically, there was a conflation of SOGI data with strictly sexual health issues. And that has created problems in how we disentangle SOGI data from a sexual health and how we put a demographic data within a larger context. Sexual orientation and gender identity data are components of somebody's identity that patients would like to share with their healthcare professionals. Again, not treating it as exceptional. People share this information and to talk about it in depth when they understand how that information is being used, how it's going to inform interventions for them individually or research and interventions for a larger population. LGBTQ plus individuals are particularly interested in providing this information and understand the value not only for their health, but how it's going to play an important role in understanding the health of LGBTQ individuals in the future. There's often a misconception that we can atomize people's identities like this. We're just going to look at sexual orientation and ways that sexual orientation relates to health. And that misses the point that these are individuals with complex, interconnected identities, that we really need to collect this information and not silo it from other data.
To recap, we've established that SOGI data are important demographic information. They're no different than other demographic data. And in fact, people want to share this information with their providers once they know how the data will be used. That all sounds fine, no problem. And yet, there is a problem of SOGI data being misused. Tell us about that, please.
State attorneys general are abusing their power by trying to extract this personal health information from health systems to target transgender people and their healthcare providers for legal sanction, for trying to get or for providing healthcare that a transgender person needs.
On one hand, SOGI data are protected by HIPAA. On the other hand, state attorneys general are lawyers, and you would think that lawyers at that level of state service would know about HIPAA. Are these sophisticated lawyers ignoring the law?
They're trying to exploit confusion, and there's a lot of it right now about access to care for transgender people. There's also not a lot of HIPAA literacy. There are elements of HIPAA that are easily confused, overlooked, or misinterpreted. For example, HIPAA allows institutions to disclose PHI in response to a law enforcement inquiry. Note, I said allows, not require. State attorneys general targeting transgender people know when a healthcare institution that is doing the work it's doing because it cares about people, not because it cares about the intricacies of any particular legal framework. They're exploiting fear. They are exploiting the fact that many people, when they're approached by law enforcement, just think, my goodness, I better comply. I better just throw my hands up and do whatever I'm told. You have this climate of fear, a climate of uncertainty, and you have state actors weaponizing that fear and confusion and seeming to require compliance in situations where they don't have the legal authority to do so.
Let's get into examples, and let's make clear that we're not talking about hypothetical situations that might arise. Each of you is aware of actual cases that have happened. Carl, what specific cases got your attention?
One of the early ones is where the Tennessee Attorney General requested data from Vanderbilt University's medical center. The medical center turned over SOGI data about patients. Even when the clinicians were adamant about not doing that, the hospital system chose to provide that information when they did not have to. That was one of the more egregious examples.
These are intimate areas of people's lives that we're dealing with in healthcare, and HIPAA was enacted to protect that information from exploitation and misuse. So it's incredibly sad to see state actors intentionally misusing the law to take personal health information from patients, from families, from healthcare institutions, not just that incredible intrusion into the provider-patient relationship, but then also to press charges against healthcare providers for providing medical care in accordance with their training and expertise. An incredible violation of HIPAA and something that should concern all of us, regardless of whether we're transgender or we provide care to transgender people. Anybody who receives healthcare in the US should be able to feel safe and secure that their personal data should remain personal. But transgender people and their providers and their families should not have to fear this extra intrusive layer of the weaponization of data against them.
Carl, you're a physician. How does that play out where you are on the front lines of clinical care?
I've definitely had this conversation with patients and family members where people are fearful of sharing this information, where they think the state may identify them and deny them access to care. The way this also plays out is people are leaving states that are essentially bad faith actors with regards to data or allowing access for care for trans individuals. And that's affecting the ability for everyone to get the services they need in a timely fashion. These bad faith actors essentially are challenging the ability for us to provide any kind of quality care for not only trans individuals, but for all patients. Threatening medically necessary care for trans people often leads to the shutdown of clinics that serve everyone. We've seen this in Seattle, where a number of issues have led to delays in care for all children, not just trans youth. So these violations of HIPAA essentially are a direct challenge to our ability to provide quality care for everyone. The ability for us to collect sexual orientation and gender identity data relies on patients trusting healthcare systems, relies on trusting that healthcare systems know how to collect that appropriately and maintain the privacy and confidentiality of that data. When we see healthcare systems acquiescing to requests to share that data when they do not have to, we are losing trust from our patients.
That brings us to the crux of the issue, trust. Who do you trust with your private health information?
Have you, as a physician, witnessed a loss of trust in the medical system?
There are multiple layers of trust that we try to engender, and a lot of that is built through the clinical encounter. And while my patients may say they trust me, they may say they do not trust the healthcare system. They may not trust the hospital administrators or making the decision about when they're going to share patient data. And while I know what's going on as an individual clinician, if they go to another clinician or if they go in for an emergency situation where they are not able to share that data, it's going to lead to a potential incident of harm for the patient if it relates to that information.
Kellan, your thoughts on trust, please?
SOGI data are really a critical element of trust, not just because a good trusting relationship facilitates the sharing of SOGI data, which are really important for patient care and quality of care overall. They're also a really important component of building that trusting relationship where people can come and share every element of who they are and trust that they will be respected, taken seriously, and given the high quality care they need when they need it. I also think it's important to remember in discussions of trust that trust is not some sort of disease that patients or communities need to be cured of. Mistrust in institutions is an entirely rational response to historical and ongoing mistreatment by providers, by institutions that so often in the past and sometimes to this day do not act with the best interests of their patients at heart. So it's not about curing patients or communities of mistrust. It's about providers and institutions becoming trustworthy so that they can invite those patients, those communities into a trusting, caring, long-lasting relationship in which people can get care they need and be seen for every element of who they are.
Carl, what are you most excited about these days with regard to SOGI data, and what are you worried about?
I'm most excited that you're seeing a younger generation of healthcare leaders understanding the importance of collecting SOGI data and protecting it like we do any other data. I'm excited that they get it. There isn't a whole lot of convincing that they recognize how it plays into individual health as well as population health. What I'm worried about in the political climate is the chilling effect or a backstep, the ability for people to trust healthcare systems. We have been working to engender or regain trust for LGBTQ individuals within healthcare, despite many years of appropriately not trusting us. And I worry that in this political moment, we are losing trust we have gained in the past 30, 40 years. And I think that's going to have long-term effects on LGBTQ health and potentially health of everyone.
Kellan, what are you excited about these days with regard to SOGI data? What are you worried about?
I am most excited by how much more common it is becoming to ask SOGI questions and to ask them well. It is entirely feasible to ask these questions and for people to answer them. And so I'm excited to see that becoming more common in surveys, in enrollment forms for health insurance coverage, as well as in the electronic medical record. The thing that I'm worried about is that transgender people will continue to be used as political pawns, as targets for a political ideology that has nothing to do with health and well-being. The thing that worries me is the providers, patients, families are being targeted by this overt ideological attack. It makes me concerned for how to make sure we can protect providers, protect patients, and make sure everyone can get the care they need when they need it.
What would you ask of our audience, and what advice do you have for our audience?
I would ask our audience to recognize that when we are talking about SOGI data, it is not strictly the domain of clinicians. It's not strictly the responsibility of the data specialist on the backside of an electronic health record. We need to make sure that everybody in the healthcare team, from first patient contact to discharge, understands that this data plays a role in people's health outcomes and that we need to make sure that stays protected. The advice I have is that absolutely you should be following best practices, and there are a number of tools out there to provide that guidance.
On June 21st, the U.S. Department of Health and Human Services Office of the Assistant Secretary for Planning and Evaluation launched a new website on resources for improving demographic data quality. There is a whole suite of materials about the collection and use of SOGI data. So a really excellent resource to help you make sure that you're asking these questions in a way that's going to yield high quality data.
Final question. Kellan, what would you like to ask of our audience, and what advice would you have for our audience?
I would love to ask our audience today to remember that LGBTQ people are just people, and that sexual orientation and gender identity variables are just data like any other type of data. And really, when you look at it, data are just stories. They're stories about who we are, what our experiences have been. They're stories about what we need. And LGBTQ people should have the same opportunity to tell the stories of their lives as anyone else. So asking the question, building the trusting relationship, and making it possible for people to share those elements of themselves, that is my ask for everyone listening. And my advice would be to do it in a methodologically sound way. The National Academies of Sciences, Engineering, and Medicine have a consensus study report that describes how to ask questions about sexual orientation and gender identity. The Office of the Assistant Secretary for Planning and Evaluation at the U.S. Department of Health and Human Services launched a website on June 21st. That is a really excellent place to start in terms of thinking through some of the questions and topics that we've discussed.
Great. Thank you both. Let's leave it there.
That's all for the second episode in our two-part series, In Data We Trust. Today's episode has been Sex, Gender, Lawyers, and the Law. Our thanks to Kellan Baker and Streed. I'm Andy Reynolds with NCQA. We'll see you again soon.